Welcome to the University of California, San Francisco Sports Medicine Podcast featuring Dr. Nirav Pandya, Dr. Brian Feeley, and Dr. Drew Lansdowne discussing hot topics in sports medicine and society. We hope you enjoy our podcast and look forward to hearing from you.
All right, welcome everyone to our UCSF Sports Medicine Podcast, 6 to 8 weeks with myself, Dr. Nirav Pandya, Dr. Brian Feeley, and Dr. Drew Lansdowne, who is not with us today. Today, we have the pleasure of having Dr. Zubin Master from Mayo Clinic. He is a PhD and a specialist in the biomedical ethics of stem cells and various different regenerative medicine topics. So we once again thank you for joining us, Dr. Master.
Thanks for having me.
Oh, of course. Maybe just start out, tell us a little bit about your background and kind of how you got to where you are and your interest in this.
It certainly wasn't a linear path. My undergrad and my PhD are in biomedical research. So I studied cell signaling as part of my PhD. I then made the transition and wanted to go and work ideally for the government and do policy work. So I did a postdoc in bioethics and health policy at the University of British Columbia and at Dalhousie University. I'm Canadian by birth. Then I got my dream job at Health Canada, developing regulations on assisted reproductive technologies and embryo and related research. But for a number of reasons, I then decided to go back to academia. Bioethics blew my mind. I thought it was a great field. I love talking about ethical issues. I think deep down, even what drove me to go into genetics was actually the ethical issues, but I never thought about going into bioethics. I thought about going into the science. And at some point, in bioethics, I actually focused more around stem cell research and ethical issues around embryos. That was really the big thing at the time. And that was a big topic. And so I went more into those types of, that type of ethical and policy issue. And yeah, that's pretty much what drove me to go into bioethics. And Mayo is a pretty cool place to work. I do a lot of research, which is what I enjoy the most, but I also get to teach some stem cell ethics and policy to students as well. And of course, the things we don't always like to do, service work.
Did you feel a little bit when, when you're going through your educational process, particularly with ethics, that the approach in Canada was different than the US? How much crossover is there, or is it kind of more of a global principle in terms of how we approach these issues?
No, I think how we approach the issues are very similar. There's certainly differences in the way US regulates things and what Canada does, but I think the concerns that people have had, may it be around, can we use a human embryo to derive a stem cell, or should we quell the unproven stem cell intervention industry? All of those types of questions are salient to both countries. Their approaches may be different, but that I think depends on who's in power, politics, all kinds of other reasons.
So you have a really interesting job, and it's pretty unique within at least for orthopedic surgeons, there's not a lot of biomedical ethicists practicing orthopedic surgery. What do you like most about your job?
I think I probably like doing the research and mentoring. I like seeing more junior scholars learn, not necessarily only about stem cells or stem cell science, but just learning, the tricks of the trade on how to get papers, how to, pitch things for specific journals, how to maybe get proposals or grant funding. I think those are the things that I like the most about my job. And honestly, I love doing empirical bioethics research. I get to talk. My job is pretty much talking to patients, seeing how they think about things, talking to physicians, seeing how they talk to patients, seeing where differences may lie or seeing where similarities are. And in that sense, I get to try to understand what makes a patient want to go and get an unproven stem cell, or what makes them not want to get an unproven stem cell treatment. And the other major cool part about my job, I get to translate things. And I never really saw that when I was doing my PhD in biomedical science. We always talk about the end result. It could help with cancer therapies. That's pretty much the area I worked in. But at the end of the day, I didn't think my, finding a molecule and seeing its function is necessarily going to translate into a therapy. I had a hard time picturing that. I know it could, but I didn't expect. But at Mayo, it's pretty good. I can take my findings and translate it, which is what I want to do. So, before I retire, if I can make a true tried and tested product that can maybe help a patient, I think that'd be a good thing to end off with.
Yeah, I don't disagree. Sometimes it's hard to get the translational work to really feel translational. Before we ask you some more specific questions, I wanted to ask you to just define what you mean when you say unproven stem cell therapies.
Right. Great question. So honestly, there is no clear definition of what an unproven stem cell therapy is. Sometimes people use those words interchangeably with unregulated as well. So it really depends. Not everything is regulated in the same way. So, the words unregulated may not necessarily be pertinent. Unproven generally means that they haven't been proven, potentially through, clinical trials, but certainly not enough science has been done to show that the intervention, the therapy, the treatment is safe and or effective. But really, I think that the unproven industry has certain characteristics, right? So it's online, it's direct to consumer. It's been characterized with a lot of misinformation to sort of, get patients to buy into an intervention, but there's no necessarily backing of it. It's obviously for profit, out of pocket. Very few insurance companies will ever be covering it, at least at this stage. Yeah, so I think that's a better way of sort of characterizing the unproven industry. There's no true hard definition of it.
In that same light, how do you feel that patients get access to this information? Like, what's most effective at kind of grabbing them in? Is it TV? Is it websites? Is it just hearing their neighbor get it? Like, what have you noticed through this process?
Yeah, so I can start by probably saying that we don't actually have that much data on how patients are getting to it. My collaborator and colleague, Dr. Shane Shapiro and Professor Jennifer Arthurs, who work at Mayo Clinic in Florida, we just put out a paper, this year, 2022. I think it came out in summer in NPJ Regenerative Medicine, where we looked at a group of patients that came in for a Reg Med consult, a regenerative medicine consult at the Florida clinic. As they came in their intake form, we gave them 3 simple questions. One of which was, as you were questioning, where did you get this information? How did you hear about it? And so this was the first study to actually find out how did they hear about these things? And not surprisingly, the number one was internet searches, not specific websites, but literally probably Googling it or, using some kind of a search engine to Google stem cell therapy, things like that. A lot of them also said that they heard about it from a stem cell clinic. So 40% of I think we had over 500 patients. 40% of them said we actually contacted a stem cell clinic. Now, I don't know what that means. Did they speak to the physician? Did they just, maybe that meant just looking up the website? I'm not 100% sure. But other than internet searches, the second biggest way was interpersonal communication. They talked to their friends. They talked to their family. They may have talked to a conventional medical physician, or they would have talked to one of those providers that's giving that unproven stem cell treatment as well. So those are the big ways. Social media wasn't up there. Television and what we call in my world traditional media, television, radio, newspapers, physical newspapers, they weren't really that prevalent. The other area, people have said that sometimes a lot of these clinics will put their intervention on clinicaltrials.gov. That also, I think we had less than 1% of people said that they heard about it from clinicaltrials.gov. So it's primarily, I think, talking to people and of course doing their internet searches.
Yeah, I think it also interesting, maybe when you looked at this as well too, is how many of these individuals are seeking that as their primary treatment, or is it because they have felt shunned by the conventional treatment? Like, I have knee arthritis, now I'm going to go to the specialist, or they have deep pain and they go right there. Have you found anything else about that? Is it more of a shunning of traditional medicine or seeking of this as their primary treatment?
Both. So we have an NIH grant where we're looking at what are the factors that make people either go and get a stem cell treatment or not go. And so we have a unique way of actually making two groups, okay? Those that are what we call high seekers, they really want to get one of these unproven interventions, and low seekers. We have found a range of different factors like desperation, trust or distrust, right? They may trust a conventional provider and distrust the person that's trying to sell them a treatment, or maybe the reverse. They may have had actually a bad experience with conventional providers and now are being sort of pushed away from them and, lured, if you will, by the unproven stem cell provider. So in that latter scenario, we have found several patients who have, and this is not just from our study, there's a few other studies that actually show that, we have lost all hope. The doctor said that they couldn't give us anything. And then a couple of our interviews that we've done actually shared quite, not really nice stories of doctors dismissing them, basically, blaming their condition on their mental health issues. People have suffered depression. People have had even suicidal ideations. And we don't, this is again what they tell us. So I think in some cases, yeah, they've had some pretty bad experiences that kind of pushed them towards something alternative. But that's not with everybody. Some people like stem cells because they consider them natural and as sort of an alternative form of stem cell treatment. We do have a little bit of conspiratorial thinking, the idea that big pharma is trying to keep everybody sick and the guy in the corner is giving you an unproven stem cell, but he's the pioneer trying to truly help you because pharma just wants to make money, and the FDA is trying to keep pharma happy, like those types of conspiratorial things. So it's really a gamut of different values and viewpoints for driving people either to get or not get one of these unproven treatments.
Kind of on the same lines, do you see when people go looking for these treatments, is it kind of all the way across the spectrum of socioeconomic status and wealth and poverty, or is it one subset or the other, or a couple of subsets that seem more prone to want to get these treatments?
Okay, good question. No data really out there. I can probably tell you that there has certainly a certain degree of income is necessary, right? These are for profit, and they could be, something cheap like maybe PRP, or something a lot more expensive where people are spending tens of thousands of dollars. So certainly, if we've talked to a few patients they're going to get one, but they just don't have enough money to get it from the specific clinic they have now identified as the one that gives the best, quote, stem cells. So definitely one of the environmental constraints would be money. The other environmental constraint would be, well, if you have a very debilitating condition where you're potentially wheelchair bound or bedridden, that's not going to be easy to perhaps go across the border to a clinic, let's say, in Mexico or something like that. That's going to be harder, even if you live close to the border. So those could also be factors, geographic distance. We've tried very hard to look at racial and ethnic diversity. There doesn't seem to be there's no quantifiable way to show that certain groups are getting and certain groups aren't. But we've tried to recruit people of racial and ethnic minorities, and there seems to be no reason why they want or not want a stem cell. If anything, probably the economic issue, as you mentioned, Dr. Feeley, is probably the big one.
Kind of along those same lines, you have a recent paper about the unproven stem cell intervention, and you call it a global problem.
Yes.
How do you kind of see this kind of playing out in other parts of the world, and kind of the feeling of stem cell in these interventions in other countries?
Yeah, it's a good question. So I do think it's a global problem, right? So we started to think about unproven stem cells. I think the first paper may have come out around 2005-ish, 6, 7, something like that. By around 2009, we started to know that there was an industry. At that time, the industry was, we thought, were in countries that had potentially lax regulations or certainly enforcement, right? These clinics were proliferating in countries like China, India, Russia, Dominican Republic, Mexico. We didn't see them in the US, Australia, the UK, Japan. We didn't see them in Canada, things like that. But in 2014 was the first paper that came out to show that there's more clinics coming out in the US. Then there were two major papers that came out in 2016. One was by John Rasko's group in Australia that showed that I think Australia, Japan, and I believe the UK had a massive rise in the number of clinics. And then another paper by Doctors Lee Turner and Paul Knopfler, which actually is focused only on the US, and at the time showed that there was about 600 clinics. And then there has been more papers that showed, clinics in Canada, and now even in the paper that you mentioned, we I think had over like maybe 24 clinics that we identified just through a quick glance at the academic literature. So it's literally a worldwide phenomenon. So in that paper, we were conceptualizing that maybe we need to think more globally, maybe we need to think about more global types of solutions. And then, we focused on potentially harmonizing regulations, because regulations are done nationally, right? So within a country, and there are differences between countries, but we were also looking at, education, right? So my whole shtick and my focus is to try to develop persuasive communication, to develop interventions by knowing how people look at advertisements, how people look at warnings, all those factors that I mentioned that could, impact somebody to go and get an unproven stem cell or not. By taking all that data, can we develop persuasive communication that can certainly not hide, we're not trying to be manipulative, we're trying to be persuasive. We're not trying to hijack your reasoning. In fact, we want to instill a sense of caution, so your rational and reasoning faculties will consider that information. We're also trying to not give a finger wagging tone. We're using empathic communication to say, listen, the choice is yours. But we haven't, as a society or as a stem cell community, really focused on better ways to. We've talked about sort of killing the. We haven't focused on the market side. Can we quell the demand side of it? We focused on the market by trying to discipline doctors, trying to make lawsuits, things like that, trying to develop regulations, but we haven't focused on the demand. Can we change people's perspectives to make them at least think twice about getting something potentially riskier, stem cells for Parkinson's or ALS or autism, and can we do that? We haven't done much around that kind of education. So I think that's probably an area that certainly globally we should all focus on, amongst others.
Yeah. And then, we speak about it globally as well, too. My training, I do a lot of pediatric and adolescent patients. Mm-hmm. And one thing I've seen is an increasing amount of interest to utilize these in kids. Like, we don't even have the data yet for adults. How do you approach that ethically when parents are the ones who are then saying, my children need these unproven treatments?
Yeah, I would say probably with the same approaches that we are using to, inform patients who are adults versus patients who are kids, especially where we can't get a consent, patients that are very young. And of course, we're relying on the consent of the parents. I think to some degree, we're not going to be able to just curtail the market with a magic wand and say, we're, problem solved, right? I think we need to use multiple modes to potentially quell the issue. And in that sense, I think that, giving people more information, maybe even targeting it for around pediatric conditions would be good. And one of those areas is autism. There's been a lot of work around using blood or blood products or blood type stem cells to treat autism. And the clinical trials haven't been, that great.
Yeah, I think that brings up a good point. We're relatively lucky in orthopedic surgery that we're treating arthritis, we're treating sometimes tendinopathies, but overall, they're pretty low stakes compared to some of the other conditions, especially when you're looking at people going and spending so much money for a neurologic cure.
Right.
My final question is kind of big picture, especially since you wear both hats as a ethicist and as a recovering basic science biologist. Do you think the US is approaching this correctly? Are we too conservative in what we're allowing? Should we allow more than minimally manipulated cells for certain conditions?
Mm-hmm. That's a good question. I think that stem cells were sort of the new kids on the block about a decade ago for sure. We didn't know how to regulate cell-based therapies, right? And so to some degree, the FDA, along with every other regulatory agency, was catching up to that. And so, were there bumps on the road? Absolutely. But I do think that the FDA, they've done a lot. They've made guidance, they've made education, they've tried to do as much as they can. They've even tried to create pathways that could speed up the process of review for certain types of regenerative conditions. So in that sense, I think it's been great. Can we allow more than minimal manipulation? From what little I remember in my cell biology days, pretty much when you take a cell out of my body and you put it just about anywhere else on any kind of medium, it's behavior change. So, you start spinning things down. Yeah, that's probably pretty, low key, but you take it out of its environmental and biological context, cells behave differently. And if we don't test how those cells behave in a patient, well, stem cells can migrate. Stem cells can form tumors if undifferentiated and not controlled. Stem cells can do whatever on earth they want. We may see adverse conditions. So, Dr. Feeley, as you mentioned, in orthobiologics, you're treating adults, and, there's been at least abundance amount of data to show that safety is pretty decent out there, right? Short from potentially, contaminating, cells that you may get. It hasn't made that much harm. Is there pain? Sure, things like that. But efficacy, especially for various other areas, still needs to be, I think, demonstrated. We're starting to get clinical evidence, but is it sort of that tier 1 level evidence, large RCTs showing clear demonstration of safety and efficacy? That I think still needs to move forward. The other areas are all over.
Well, thank you for joining us today, Dr. Master. It was just, we could have like hours and hours of talk about this. We're just touching the surface, but thank you once again, and hopefully we'll touch base again soon. We appreciate it.
Thank you.